Next, I'd like to introduce Jean Botha, Greg Fitzke, and Dr. Mike Zaruba, who are all with us from Nebraska here today. They'll be speaking about surgery, when, where, and how.
Well, good morning. I'm privileged to have an opportunity to talk to all of you today. As Nancy said, I'm from Nebraska. My name is Mike Zaruba. I'm a primary care physician. And I got involved with Carcinoid because I have the privilege of taking care of some wonderful patients. It was kind of interesting to listen to the author talk about her book because that's what I do every day. I listen to people tell me about those symptoms and try to figure out what flushing is flushing from carcinoid and what flushing is from some other reason. And there is a big difference. I had the opportunity about 2 years ago to meet a young lady by the name of Ruth Gertis. And Ruth came into my office primarily because of an issue that she had with a life insurance. She had gone through a procedure and someone said, well, why didn't you follow up on this abnormal liver spot? And of course this was news to Ruth. She didn't know about it. And ultimately, through a course of a very difficult workup, we were able to establish that it was carcinoid. And she had pretty significant disease in her liver. Ruth is the type of person who, the best way to put it is, she's very energetic, she's very determined, and she will not accept anything less than the best. And we went through numerous consultations. I consulted with just about every expert in the United States. We talked about different options. We talked about nutritional aspects. We talked about everything related to carcinoid. And ultimately, through a very collaborative effort with Dr. Greg Fitzke and Dr. Jean Botha, we came up with a plan for surgery. And we resected her primary, and at the time of the primary, Dr. Fitzke realized that her liver disease was very extensive. We knew it was extensive going into it, but you get in there, he knew that there was more than he could do. And ultimately, we ended up at the University of Nebraska with the best transplant surgeon, Dr. Jean Botha, and he came up with a plan to surgically resect this liver disease in a 2-stage process. And I will tell you that Ruth, of all the experts I talked to, he was the only person that would even consider doing surgery. Everyone that I talked to said, nah, her disease burden's too big, we need to go this route, we need to consider these things, many of the things that Dr. Wolin talked about. And with Ruth's determination, she was bound and determined we were going to get to a disease-free state. Ultimately, Alicia Egan came into my office shortly after that, went through the same procedure, and we've since duplicated the procedures in some form or another numerous times. So I'm going to turn it over to Dr. Botha. He's got the meat and potatoes of this talk, and then we'll open it up for questions afterwards.
Thanks, Mike. And as I've always said, giving these talks, I didn't start off as a carcinoid expert, and I still don't claim to be an expert in this disease. But what I do say is that I am an expert liver surgeon, and that's where my role in this has come in. So I'm going to discuss our approach at the Carcinoid and Neuroendocrine Tumor Clinic in Nebraska, our approach to the surgical part of treating this disease. This is a multidisciplinary clinic where we have radiologists, medical oncologists involved in the treatment of this disease. So I'm a transplant surgeon. I was transplanted from the tip of Africa. I now work in Nebraska. I've been there for 8 years. And I would never have thought I was going to stay there, but the place has been very good to me, and we've done a lot of fun things. So where I come from, at the tip of Africa, we have mountains, we have beaches. It's a beautiful, beautiful country. But what we also have a lot of is wild animals, and this one in particular. Now, I'm going to talk about liver resection. You're going to wonder why I showed the zebra, but what we are going to talk about is the case for liver resection, which clearly I'm a proponent of, in that although we don't have any randomized studies, measuring the outcome of surgery against against people not getting surgery and against any of the agents we've heard about already today. But I do think it improves survival. We know it alleviates symptoms in patients who have the syndrome, and we think it can also prevent cardiac disease. The case against it is, as most of you often get told, this is a slow-growing tumor. You can live with it for a long time. And these are, in essence, complex operations that could really jeopardize patient survival. So the way I look at the types of liver diseases, and I bet most of you didn't know there were 3 types of zebra. There's the plain zebra and the mountain zebra. Burchell's, these two are both found in South Africa. Burchell's is a type of plains zebra. Cape Mountain zebra, found down in Cape Town. Gravy's zebra, named after a French president, is found in East Africa. This is how I look at metastatic disease in the liver. There are 3 different patterns. There's the single metastasis, one large lesion, sometimes hopefully even a small lesion. This is not a metastasis, that's a cyst. Then there's the type 2, where the bulk of the tumor is all in the one lobe, but there are smaller deposits elsewhere. Here's one out in the left lateral segment. And then there's the type 3, which unfortunately is all too common, which is widely disseminated disease with virtually no normal liver at all. So in this context, that's how I approach the patient with metastatic disease in the liver. If we look at the solitary or type 1 disease, this is the same CAT scan I showed you. This is a patient with one single large metastasis sitting in the left lobe of the liver. The results of surgery for this is excellent. Unfortunately, it only accounts for about 20% of patients, but this is a recent study that came out in the British Journal of Surgery this year from a German group, and the survival is 100% at 10 years for patients who undergo complete resection of a type 1 tumor. I mean, that's dramatic results. I'll cover type 3 quickly because from a surgical point of view, there's very little to do here. Nothing is resectable, and there's possibly a role for transplant, but only in highly selected patients. The results of transplantation in this scenario carries a high morbidity and mortality, and it usually is restricted to young patients, generally under the age of 50. So let's look at type 2, because this is where we've become a little innovative. And again, I've 3 strategies in approaching patients with type 2 disease. Now remember, this is patients with the bulk of their disease in one lobe and smaller disease scattered throughout the other lobe, or the contralateral lobe. So schematically, we have 3 ways of approaching this. First is a single stage resection. You can go in and with either just cut the tumor out, the single lobe out, and I'll discuss that, or the 2-stage resection, and I'm going to show you a little about that, or transplantation. So the single-stage hepatectomy is, as you saw that patient, you can remove the right lobe of the liver and either do wedge resections of disease in the contralateral lobe or use intraoperative radiofrequency ablation to ablate the tumors in the contralateral lobe. We can also use preoperative portal vein embolization, and I'll show you a little about that. Portal vein embolization allows you to take bigger and bigger pieces of the liver because it stimulates the liver to grow. So this is a patient that I did a single-staged hepatectomy on, who had all this disease in the right lobe, and there's some scattered stuff in the left lobe. The patient had a preoperative portal vein embolization, and this is the portal vein that you heard Dr. Wallen mention earlier that drains all the blood from the bowel. This is already within the liver. There's contrast that's injected into the portal vein. It divides into a right portal vein and a left portal vein. Now this patient had all that tumor in the right lobe. What blocking off the blood supply to the right portal vein does, here the radiologist has inserted these little coils that occludes the blood supply. There's no blood supply going into that right lobe of the liver. And that sends messages to the left lobe of the liver to start growing. So ultimately, with this little left lobe, which normally would have been unsatisfactory for the patient to survive after resection, now becomes bigger. And we can take bigger and bigger pieces of the right lobe of the liver and have the patient survive. This is what the patient looked like after. So we removed all of this, and here's this left lobe of the liver, which has grown quite substantially, and this is a few weeks after the resection. No disease in the remnant left lobe. It's a similar scenario. This is a patient who underwent right hepatectomy, and you can see small deposit in the left lobe. We didn't have to do a portal vein embolization. We were just able to do a right hepatectomy and wedge out a few lesions in the left lobe. So what about the two-stage hepatectomy? This is the schematic diagram of what happens. So the patient starts off with a number of tumors scattered out throughout both lobes of the liver. In the first step, what we do if the patient still has their primary tumor in sight, through a midline laparotomy, we would go and remove the primary tumor, whether it's a distal pancreatectomy or a bowel resection. We avoid doing tumors that are in the head of the pancreas, doing a Whipple procedure at the same time as a hepatic lobectomy. So if it's a distal pancreatic tumor, remove it. If it's a bowel tumor, we'll remove that. And then wedge out all these tumors out of the left side of the liver. What you've got to imagine is that we're going to create a future liver remnant. This is going to be our future liver. We're planning to remove all of this at some point. So we make this liver look like a piece of Swiss cheese. We go in there, this left lobe is what we're going to keep. We take out a bunch of tumors out of that, either wedge resections or radiofrequency ablation. And at the same time, we tie off the right portal vein. And what that does is then stimulate growth of this left lateral segment. Again, it grows, and now it's forming, what started out as 25 to 30% of someone's liver is now 45% of their liver. And then weeks to months later, once that liver has grown, and we check with CT scans to make sure that the volume of liver has grown, we then go back and do the right hepatectomy, remove this part of the liver. Now we've essentially got a liver that has no tumor left in it. This is an example of a patient that we did this on. Large bulk of tumor in the right lobe. You can't see it on this picture, but a huge tumor sitting in the left lobe. We resected this tumor out of the left lobe, multiple other tumors out of the left lobe as well. Did a right portal vein, on her we didn't ligate the portal vein, we went and did a portal vein embolization, because at the time there was some data to suggest that the hypertrophy of the left lobe of the liver was better with embolization as opposed to just tying off that portal vein in the operating room. So we went in and did this portal vein embolization, allowed the left lobe of her liver to grow. You can see this liver looks lumpy, bumpy. This is where I've taken a pitching wedge and divoted out all these tumors out of the left lobe. And you can see the remnant tumor in the right lobe. We then went back. This is what it looked like just before we went to operate. This is the previous scan. Now, having taken out that right lobe of her liver, she's got this enormous left lateral segment which has grown. And this is a few months down the line, showing a very good response. Similar story. One of the other patients that we've done this on, these are the initial scans down on the left side. These are the scans after the first operation, and these are the scans after the second stage. So the patient starts off with huge bulk of tumor within the right lobe of the liver, a few smaller deposits elsewhere. You can see them out. This is actually, she already had a pretty big left lateral segment to start off with. You can see it going over the spleen over here, but a few deposits within the left lobe. So we went in, wedged out all these deposits. On her, we ligated her right portal vein at the time of the operation. 6 weeks or 3 months later, we went and took out this entire right lobe, and this is what a liver now looks like. Again, it doesn't look very pretty, but it's big enough and it sustains her. So this is just, again, schematically what happens. This is what we're going to identify as our future liver remnant. This is the thing we're going to make Swiss cheese out of. Again, after we've made Swiss cheese out of it and ligated the right portal vein, that's what happens. Now I didn't come up with this idea. This is a French group who first started doing this for metastatic colon cancer, and were noticing improved survival. They then published last year their results on a group of patients with metastatic neuroendocrine tumors, having done the two-stage procedure. And while the recurrence rate is relatively high, 60 to 80% of patients getting recurrence by 5 years, their survival is excellent. 80% of patients are alive at 8 years, doing very well. So what was our little experience? As I said to you, I've only been dealing with this disease for a short period of time, so I can't boast any long-term survivors at this point. But since treating this first patient that Mike mentioned to you, I've seen 15 further patients all with metastatic carcinoid. 10 of these patients are suitable for major resections. We've done 6 single-stage resections, 2 with portal vein embolization, allowing the left lobe to grow and being able to then take out about 75% of their liver. 2 with radiofrequency ablation to treat tumors in the remnant left lobe. And then I've done 4 of these 2-stage resections. All these patients are alive. 90% of them are symptom-free, and all our patients have got through this operation with relatively minimal complications. One patient had to go back for residual disease, which we resected again once that left lobe had grown, and treated with radiofrequency ablation. So I'm going to stop there, and I'll be happy to field any questions about this. But I strongly feel that radical surgery these days can be safely performed. It gives excellent relief of symptoms for the patients who have the syndrome. And while I can't boast any long-term survival, these are coming out of the literature now. Thank you very much.
Should we ask questions
I think so.
for 3 of you at once? Okay, do you guys want to go upstairs?
While you're getting up, I had a question for Dr. Wolin, if it was possible.
Oh, lovely. We
With the-
encourage
with-
scientific collaboration.
Yeah, with the results that we're seeing with the long-acting octreotide in all these drugs, in terms of stabilization of disease, obviously there are no studies looking at these drugs as adjuvants to the surgical situation. Now, I've got a bunch of patients like this that are now macroscopically tumor-free. Would you recommend, are they symptom-free and tumor-free, would you recommend putting these patients on long-acting octreotide as an adjuvant? I mean, it's well-tolerated, otherwise fairly benign drug.
The answer is yes. I personally would put all of these patients on a somatostatin analog. I think whether it is octreotide or there is a trial now with lanreotide, but I think that octreotide is definitely recommended. I think in anybody with carcinoid syndrome having radical surgeries like this, it's actually a good idea to be on octreotide preoperatively.
Yeah.
One of the risks of surgery, of course, is having a carcinoid crisis induced by anesthesia and manipulation of tumor. So I think it's a good idea that these patients should be on octreotide, and in fact, I'm sure you're doing this, putting them on intravenous
Absolutely.
octreotide as a continuous infusion before, during, and after surgery to prevent a carcinoid crisis. So that, and then I would maintain them on octreotide postoperatively as
Okay.
part of the management.
Thanks.
Lovely. Dr. Botha, would you describe to us a little bit about the Carcinoid Center that's being developed at the University of Nebraska Medical Center?
Absolutely. Well, it all started with this one patient who came to us and was very grateful for what we did for her, and has been an absolute crusader for carcinoid and other neuroendocrine tumors. And it's because of that and we started seeing more patients, we've decided, well, you know, this is a disease which appears where we are to have more of a prevalence than we previously had thought. So we felt it behoved us that we needed to do this for our patients. We needed to set up a center where patients could come and get advice, could get treatment, could get a multidisciplinary approach to their disease, their questions answered, and have a really a focused approach to this disease, which, you know, for a long time has been somewhat of a medical curiosity, and rather than people taking it seriously. And there really exists, where we are in the country, nothing like this. So with the number of patients that we've seen, we felt obliged that we have to actually do this.
Yes, I think I can speak for everyone when I say that we're really grateful to have such a wonderful center.
Thanks.
And following up on what you were saying, Dr. Botha, about the cancer clusters, is that something that you or, I know Dr. Zaruba has spoken a little bit about that, because the patient that you treated initially was from Auburn, and for some reason there's been some sort of cancer cluster. I know that a lot of us have heard about carcinoid and related neuroendocrine tumor cancer clusters across the country. Do you want to speak a little bit about that, Dr. Zaruba?
Well, I can. I became a carcinoid primary care physician, if you will, because I'm not an expert, and I'll never call myself an expert. Because there's 7 cases of carcinoid in a town of 3,500 that I live in. And to give you some idea, I think it's still safe to say most primary care physicians who do what I do may be lucky if they see 1 or 2 cases their career. I actively take care of 7 from my hometown. Most of them are in a disease-free state. We believe, and again, this is where I think we need to have some research, and hopefully we have a great epidemiology department at the University of Nebraska, and we need to look at this. But, we certainly believe with where we're at, agriculture is huge, and, the use of pesticides and things, that all leaches into the water, and it's all, and it goes back to kind of even the nutritional talk, it's nitrates in the water and stuff, and so we need to look at that and see, we believe that probably is in large part what's causing what we're seeing, but nobody's proved it, and we need to go and look at those kinds of things. So there is definitely a cluster where I'm from.
Thank you. Dr. Botha, turning back to you and these surgeries that you've performed, and I wanted to ask you if you could talk a little bit about the side effects that patients go through and what kind of, in between the 2 procedures, what that's like for the patient, what complications may arise during that and after, and if patients come to see you, if there's something you recommend that they do before coming to see you to sort of improve their chances at reducing these side effects.
Well, there's absolutely no getting away from the fact that this is big surgery, and big surgery is associated with big complications. So, we've had 1 carcinoid crisis on the table, which we were able to, that was despite getting somatostatin infusion. We've had a couple of strange complications. One patient developed a diaphragmatic hernia where the right lobe of the liver was, and needed to be operated on for that.
Would you define that for our audience?
A diaphragmatic hernia? The diaphragm is the muscle that separates the abdomen from the chest, and the right lobe of the liver sits under the right hemidiaphragm, underneath that muscle. And when we're taking away this big piece of liver, there leaves a bit of a void there. That usually fills with fat and bowel, gets up there. But in this instance, there was a defect in the diaphragm, a little hole that we'd obviously made or was weakened from 2 surgeries. And the bowel then went up into the chest, and that required emergency surgery. One patient had to go back for bleeding after the second operation. So absolutely no getting away from it. We've had hernias, just incisional hernias in one patient. Another patient developed an abscess adjacent to the right lobe of the liver, which needed to be drained. That ultimately ended up having a tube stuck across the diaphragm and resulted in an infection around the lung. So the complication rate is high. It's in excess of 35%. It's a small series, but just about everyone's going to have some form of surgical complication. They're not minor. We tend to avoid the minor ones because that's the stuff we do every day, preventing wound infections, urinary tract infections, deep vein thrombosis, pulmonary embolus. That's stuff we work hard at after any abdominal surgery to try and prevent. In terms of what patients can do to make it better, obviously the leaner, healthier, fitter patient is the one that recovers, is the easier operation, and the one that recovers quicker from such a big surgery because, again, it's 2 incisions across the belly. You've got to get out of bed first day after this operation. You've got to get up, moving, walking, coughing. And so the 300-pound person is going to struggle as opposed to the 150-pound person that we do that operation on.
And turning to your experiences as a liver transplant surgeon, so one reason why you're able to reduce complications is because of your extensive experience in transplanting livers. Turning to your talk, to what you touched on in the talk about transplanting livers as an option for someone with Mets to the liver, when is that a possibility? I know you mentioned it was very rare and only for people under the age of 50 and so forth, but also, is it really, let's say there was a viable candidate, would that person really be able to be on a liver transplant list and obtain a new liver, even with having existing cancer in their body?
So the patient has to have metastatic disease confined to the liver. The primary tumor has to have been resected and controlled and no evidence of recurrence. If there's tumor elsewhere in the lung or still nodal disease in the abdomen, that rules the patient out. It's usually for the patient who is very symptomatic, whether it's from tumor bulk because of discomfort and pain, or from uncontrolled hormonal symptoms. The patient is no longer responding to medical therapy. The problem is that, as I said to you, the morbidity and mortality is high. At 1 year, for all liver transplants, at 1 year, 10 to 15% of our patients are going to be dead because of what we've done to them, because it's such a big operation. So you're already taking, that comes off the top. So 10 to 15% of patients will die within the first year of liver transplantation, all comers. It's a little higher for the patients with neuroendocrine tumors. And that's just the small series that are out there. So we're looking at probably 80% 1 year survival after liver transplantation. But bear in mind that this is almost a palliative operation for uncontrolled symptoms. And that's why I say under 50 years old, because it's such a tough operation. The person who's 60, 65, while we do transplants on those patients, we do transplants on 70-year-olds, but they're imminently dying from their liver failure. These patients tend not to be. In terms of getting them on a transplant list, there are two options for transplantation. One would be cadaveric donation, where you go on a waiting list and you wait, or living donation, where friend, family volunteers a portion of their liver, and we do that. In order to get the person on the waiting list, we have something called a regional review board, where we would request that a patient gets points. All patients on this list are scored, and we would request points for this patient to be able to compete with other patients who have liver failure. So they get points almost equivalent to somebody who has hepatocellular cancer on this waiting list. So they're patients with metastatic neuroendocrine tumors that we do transplant are sitting towards the top of our list. So they tend to get done, certainly in our center, within about 6 months of listing.
I remember the last time we spoke, you mentioned that you were learning a lot about carcinoid patients and resection and doing these procedures. Can you describe a little bit about what you've been learning and how you've been refining your technique? Yeah,
I mean, so the first patient I did, the first time I operated on her, I mobilized the entire liver, and that was a stupid thing to do, because that made it so much harder to go in the next time to take out the right lobe of the liver. It's little things like that that I've learned to rather stay away from what I'm going to be touching the next time. It would seem obvious right now, but when you're looking for all these tumors in the liver, the best way to do is mobilize it. So I tend to stay away from the right lobe of the liver that I'm going to take out in the second stage. Just concentrate on the left lobe and don't go anywhere near it. Leave it as it is. It makes it easier for the second operation. So, I mean, that's the biggest lesson. The next one is the right portal vein ligation, whether to ligate the portal vein or to have the radiologist embolize it. I'm doing both at the moment, but again, right portal vein embolizer. Going to ligate the right portal vein, again, you need to dissect around there, you need to dissect up into the hilum of the liver to do it, rather just stay away from there. So I'm tending to use portal vein embolization, have the radiologist do it between the two procedures now. So those are the little things that I've learned.
Wonderful. And do you notice a common thread between your carcinoid and related neuroendocrine tumor patients and your other very ill patients that you treat? Is there a commonality that you see, or are there more differences than commonalities?
No, I mean, the other patients that I treat obviously have metastatic tumors to their liver from generally colon cancer is the commonest, but other gastrointestinal malignancies. Those patients tend to be a little sicker. They're getting chemotherapy, that kind of thing, before we operate. Some of them start with chemotherapy. We operate halfway through the chemotherapy, then complete chemotherapy. So those patients tend to be a lot sicker.
I see.
The neuroendocrine tumors, especially the ones we can resect, their livers are completely normal. They generally haven't been exposed to cytotoxic chemotherapeutic agents, particularly the new drugs that have been used for colon cancer, which do have a damaging effect on the liver. So, provided the patient's resectable, the carcinoid and neuroendocrine tumor patients I find are easier to operate on. And so
a follow-up question would be, if a patient has received chemoembolization to the liver, would that be a more difficult procedure for you?
Again, it's almost the same. You want to be able to keep this a functional remnant of liver there that's going to grow. And if there's been too much damage to that, it can rule it out. Hopefully, if it's somebody who's had tumor in the right lobe and it's just been a right-sided portal vein, hepatic artery chemoembolization, that will not rule them out. Again, the experience with resection after TheraSpheres or SIRSpheres, there's very little. Again, most of that's been in the liver transplant world, where we've given it for hepatocellular cancer and then gone and removed the whole liver.
I see.
But it would less likely impact surgery than would hepatic artery chemoembolization, which could be a bridge that we can't go back across.
And what have you observed, and what do you feel is the role of the patient's caregivers in the ICU and in helping the patient?
Well, in Nebraska, we've got a great experience with this because we're in a fairly remote part of the world, part of the country, where our patients come from all over, not only Nebraska, Iowa, North and South Dakota, Kansas, Missouri, that kind of thing. So they're away from their families. So we have a hotel facility on our campus, which most insurance companies will pay for meal and lodging for family. We have a fairly open sort of policy in our intensive care unit where families are allowed to be there, just not when nurses are changing over, but there are no visiting hours that you have to be there between 5 and 7 or something. It's a fairly open policy that immediate family members are allowed to be there. So we try to discharge the patients to their caregivers very soon. So average hospital stay is going to be around 5 to 7 days in hospital, and then the patients go to this kind of step-down hotel facility where their caregivers are actually taking care of them, doing the dressing changes, making sure they're taking their medications, getting them down to physical therapy, getting them down to the lab to have their daily lab test done. So we try and get them out of the hospital quickly and put them in the care of their caregivers, which we found, in this situation works very well.
Wonderful. Thank you, Dr. Botha. I'd like to turn to Dr. Fitzke. And one remarkable aspect of this story that I learned when I was in Nebraska visiting with the patient that these 3 doctors treated is the unbelievable collaboration of Dr. Zaruba, Dr. Fitzke, and Dr. Botha. Each person worked together to bring her the best care possible. And so, Dr. Fitzke, you were instrumental in this collaborative process. And I'd love to ask you a question about what can patients do, in your opinion, to help foster the relationship between the primary care doctor, the surgeon, or the carcinoid expert. And if there isn't a working relationship among all of them, such as the 3 of you have now, what do you feel the patient should do to encourage that or increase it?
From that standpoint, the patient probably needs to do as much self-education as possible. This is an entity that we do not see that frequently. The reason that this collaborative effort worked is that we each knew our role, and we each knew that there was certain things that we were going to be able to do for this patient, certain things that we were not. Physicians don't always recognize that. We're fallible. We're human. Each physician plays his or her own role in the care of the patient, but the patient also has to take on a responsibility that has now been thrust upon them to educate themselves, and in some ways educate their physicians in the role that they play in their care, and to always be an advocate. Never believe that the physician is the unbiting resource or the all-knowing individual, and if that person provides you with an answer that does not seem acceptable to you, never let that just rest as the final decision. There is a lot of responsibility on our part to take care of patients. There's a lot of responsibility on patients to take care of themselves and to make sure that they get the treatment that they need, and never be inhibited by a physician who may be a little standoffish, a little threatened by his or her own inexperience or inability to take care of a problem. Not to toot our horns, but Dr. Zaruba knew he had a patient that needed a surgical procedure. He called me, we did a surgical procedure, and I knew that going after the liver was not something that I had the capabilities of in my own hands, nor the resources to take care of in my facility. So it became a stepwise fashion. It doesn't always have to be. There can be times when you recognize and have a high index of suspicion that there is going to be more needed for a given patient than you can provide that individual with, and you have to look at yourself and you have to say, I can't deal with this, you need to go someplace. Our first patient, quite honestly, could have potentially had several things done all at once. It's not the way it turned out. But the fact of the matter is we have to recognize as physicians that we do have our limitations. And sometimes we're not allowed that luxury. Sometimes, as Dr. Woolen described, people show up with bowel obstructions. You don't have time to do a lot of extra research and try to get that patient to a facility where the Dr. Bothas of the world exists so that this can be approached in a more systematic manner. Sometimes you have to deal with the situation at hand, but the key is always advocating for yourself, always pushing your physician to do the right thing, asking all the right questions, educating yourself, and never be afraid of your physician to look at them and say, hey, it's time to move me on elsewhere, or what do I need to do for the next step?
Dr. Fitzke, if a patient has an exploratory laparotomy resulting in multiple tumors removed from the abdominal area, 2 feet resected from the small intestine, and then experiences digestive problems post-surgery, what would you recommend? Are there certain symptoms that can accompany an intestinal resection? Is the tendency for patients to only tolerate bland white foods after this type of surgery?
In those particular situations, you have to identify where the symptoms are coming from. Are the symptoms a result of obstruction secondary to the surgery in and of itself? Anybody who's undergone an exploratory laparotomy and a bowel resection is at risk for adhesion, scar tissue, and further bowel obstructive type symptoms. But obviously, as we pointed out earlier, there are certain things with carcinoid and the resection of small intestine that can lead to nutritional problems. That's where a collaborative effort once again comes back into play. Having experts such as our nutritionist described earlier, we again, as physicians, we have to realize that we have to identify what we feel is the problem, isolate that, and get the right people involved to help solve that problem, because we're not going to have all those answers ourselves. If the issue is obstruction, if the issue is an obstructive process that prevents that patient from getting adequate nutrition and continuing to heal and continuing to thrive, then the answer may be a second operation to lyse adhesions, resect further segments of intestine that could have become obstructed from the first operation. Or if it's a nutritional issue, then you need to get the right individuals involved, such as our registered nutritionists, to help create sort of an individualized diet and nutritional plan so that they can continue to thrive.
Wonderful. And what is CyberKnife, and how do you think it can be used for carcinoid and related neuroendocrine tumors? Why is that funny?
I just asked him about it yesterday.
Oh, good question, whoever submitted that.
Yeah, it just so happens that in Lincoln, Nebraska, we are a relatively newcomer to the CyberKnife facility. Trying to, again, educate myself and trying to stay on top of potential other therapies other than just what I can do with a knife. I did go to a training course. It was inefficient at best. I do not know exactly where CyberKnife is going to fall out in the potential treatment of carcinoid therapy. I think that there is going to need to be a lot more research done. At this point, I do not see CyberKnife as a substitution for a well-performed surgical procedure for the same indications. But yet that technology is evolving. And so do I think that it may eventually play a role? It might. But right now, I don't believe in heart of hearts that the CyberKnife technology simply replaces the surgery that can subsequently be performed in a safe and efficient manner in potentially the same individual. Now, in an individual such as stage 3,
would you define, I'm sorry to interrupt, would you define CyberKnife for our audience, the CyberKnife technology?
CyberKnife is radiosurgery. It is providing ablative doses of radiation in a manner that is similar to resecting a tumor per se. And so it's a new radiation therapy that mimics surgical resection more so than standard radiation therapy currently. There's only, I don't even know how many places there are in the world that are doing this. There aren't that grand a number, but again, you always have to be critical of new technology, because there's always somebody out there who's got a hammer and then the entire world looks like a nail. And so we've simply got to be very critical of all new technology to actually prove that it can be more efficient, can provide better outcomes than the standard therapies that we currently have. And at this point, I really cannot tell you that I know how CyberKnife exactly is going to fit into the treatment of carcinoid therapy, carcinoid tumor.
Thank you. And then when when the three of us had our video interview out at the University of Nebraska Medical Center, which is available to any of you, please just contact the foundation. We had an interview with the patient that we keep mentioning, and also with these three doctors on a very in-depth conversation about the surgical procedures. You stated that doctors need to use a high index of suspicion when a patient's symptoms don't add up. Do you feel that now is the time to get the message across to all in the medical field that carcinoid and related neuroendocrine tumors may not be as rare as thought, and this should be perhaps more addressed in medical school or medical conventions? And I'd be interested in your opinion or anyone's opinion.
You know, I think from the primary care role, my colleagues probably don't like me saying this, but it's the truth. We need to step up to the plate a little bit in family medicine, internal medicine, and educate ourselves, because there is a lot of physicians out there that don't know a lot about this particular disease. We still have to keep in mind that there's this adage in medicine that when you hear hoofbeats, you think horses, not zebras. This is definitely a zebra, but it's a more common disease than I think we're giving it credit for. And I think we need to step up to the plate. We need to not dismiss the vague symptoms. I mean, I can't tell you how many people I see in a day who have hot flashes. Was it a hot flash or is it a flush? You know, you have to have an index of suspicion for it, or you're never going to diagnose it. If you don't think a carcinoid on your differential, you're not going to think of it. I think education at the medical school level, I mean, we hear about this disease, and I think in the same sentence, probably all of us heard, oh, you'll probably only see one, or you'll never see one, and maybe that's where we need to do a little bit more education. But I think it's also imperative. I've learned more from Ruth Gerdes than any patient I've taken care of. And she would come into my office with more research, and I made the mistake. I told her it was my fault. I said, I will work as hard for you as you work for yourself. Well, little did I know how hard I was going to be working. You know, and I think it's a testament to Ruth. You know, she's taught me a lot about being a doctor. And it came, you know, from her getting her nose to the grindstone. We explored all kinds of options. And Ruth's case was difficult. And a large part of her case, and Dr. Fitzke won't take credit for this, but a large part of her case was getting a surgeon to listen to me, because I had a very vague case. I had a lady that, well, these may or may not be hemangiomas. They're probably nothing to worry about. Why don't you scan her in 3 months and see if they're changing? And the radiologist, we'd done a CAT scan, we'd looked at a lot of different things, and things just weren't adding up. I finally went back to the radiologist and I said, something's wrong here, we're missing something. And, you know, the radiologist, I think just to appease me, said, well, I'll look at it again. And lo and behold, 2 months earlier or 6 weeks earlier, they'd missed the mass, the primary carcinoid. So then I called Dr. Fitzke and said, hey, you know, this is what I got, I don't know what it is. You know, can we get her to surgery and figure this out? And that's where the collaboration comes in. It's about taking care of the patient. And if I don't have a surgeon that's going to listen to me, then, you know, the process stops right there. And then the process keeps going. He gets her in there, he realizes it's frozen section, it's a carcinoid tumor. He stops so that we don't mess up the liver for our liver surgeon. And that's where the whole process of Ruth's story has kind of come about. It's as much about carcinoid as it is about the collaborative process that went on. And we talked about individual treatment, and I think that's absolutely the only way you can approach carcinoid. I think the treatment for patient A versus patient B versus patient C has to be completely individualized. And you have to look at, because there's a lot of things here a lot of carcinoid patients here that wouldn't be a candidate for what we're talking about, but we need to diagnose it earlier so we can make them candidates for this, and we need to keep educating people. And we appreciate, I appreciate as a physician being educated by my patients. It helps me a lot.
As you can see, this is a really wonderful story. And Dr. Zaruba, following up on the cluster patients that you found, do you know if there was similar pathology? For example, if it was a similar Ki-67, P53, et cetera, type data that was compiled on all of these patients? Or do you not have that information yet?
Well, I have some of that information. I think one thing that would really help us a lot is getting a tissue bank and being able to look at that. The patients we're talking about from my area all had very similar Ki-67s. They were all less than 2%. And, you know, and I believe a lot in that marker. I think it tells you a lot prognostically. You know, and so, but as far as similar features, I mean, I'm sure they were similar. I mean, they're neuroendocrine tumors, but actually the tissue bank, I think, would be something that would be, you know, valuable to be able to, you know, have some of these tissues banked, and so as new treatments come out, we can go back and look at some of these issues. And that falls outside my area. I'm a primary care physician, and I'm not a medical oncologist. I'm not a researcher. And so, you know, I look to those experts, just as like Dr. Grimm in our multidisciplinary clinic. I mean, that's going to be a role that they play, and I think that's probably, Dr. Woolen can probably answer that question better as far as how much that's going to be helpful, but I think it will be to be able to go back and look at tumors and when new treatments come available.
Dr. Zaruba, how can patients encourage their primary care physician to become more active in their care? And what are things that patients should look for in their primary care physician? I know we've sort of heard you talk about how important the role of the primary care physician can be, but how can patients exhort their PCPs to be more active?
Well, I think you have to challenge them, for one thing. I mean, you know, I think you have to do the research. I mean, I don't think you have to go out and read medical journals in the sense of doing that, but I think you need to look at different options. Especially with carcinoid, I mean, I am now, but at the time I couldn't tell you who one expert in the field was. I can probably tell you, you know, all the experts now, because you end up doing that research and having people bring you in information and as a primary care physician, not discounting it. I mean, if it's something, you know, if it's the quick fix, the miracle pill that, you know, for $799 you can get it off the internet, it's going to cure every cancer. I mean, you need to be, I got to tell them, hey, okay, this is not something good. But you don't discount the knowledge they bring in. Ruth brought me in stuff that, you know, you'd look at it and I'd try to figure out how she found it, you know, and it was great information, you know, and we looked at lots of options before. It was probably, I'm trying to think, a 4-week process before we ever really got Dr. Botha involved. We looked at numerous centers, looked at numerous things, and so I think you got to you know, be able to bring that kind of information to your physician. And then, as Dr. Fitzke said, don't be afraid of your physician. You know, if your physician's afraid to get a second opinion, get a new doctor. I mean,
I think that bears repeating, actually.
You know, because that's just basically, you know, that's what the role of the primary care physician has to be. You know, that's what I have to do.
And in addition, you do other things to follow just the normal, everyday health care of your patients with carcinoid, in addition to helping them with carcinoid.
Yeah, I mean, we've been, and I haven't even had a chance to talk with Dr. Botha, but we'll use Ruth. We keep talking about her, but we're starting to find that there's probably some things we need to be doing from a physical therapy standpoint following these surgeries. Certainly nutrition is a big role. We have a nutritionist in Lincoln that we use. The nutritional, you know, talk is a lot of the same things that we've been doing. You know, and then post-operatively, it's kind of, unfortunately, a little bit of flying by our seat of our pants on how you follow these patients, because there isn't really a book to go look at them. But, you know, that's my role too. I rely a lot on Dr. Botha in following these patients, but I also, you know, need to be aware if my patient, you know, if it's been 6 months since we've done a scan and we were supposed to do one in 6 months, that's my responsibility. It's your responsibility as a patient also, but it's a team approach. And so, those kinds of things, following markers. I think there's a big side of carcinoid that we have to look at too with people that are having this surgery. They have high serotonin levels. All of a sudden you're pulling that serotonin out of their body, or at least you hope that you get to a disease-free state and there's very minimal serotonin. That's got, in my mind, and again, I don't think there's lots and lots of studies out there, but I've read some, that's got a huge emotional component that as a primary care physician I have to address. And we had one patient, you typically don't put carcinoid patients on serotonin reuptake inhibitors, which are, but we had to put a patient on that because she was depressed following the surgery. And I have no doubt in my mind that it was due to, the need for re-regulation of her receptors. And I think that's an aspect we're going to have to look at as we go forward. That's much more common in the people with syndrome. Ruth didn't have syndrome. Ruth is a unique challenge following surgery because she didn't ever have a marker that was elevated. So, how do you follow those markers? So there's lots of issues like that we follow.
Thank you. Dr. Botha, a couple of questions. What are important markers to monitor for liver function?
Those are pretty easy, actually. Straight after a liver resection, we look at something called the INR, or International Normalized Ratio, and that's a measure of how your blood clots. Within about 5 days after a liver resection, that should return to normal. The other liver function test, we look at something called bilirubin. Again, within about 5 days of a major liver resection, that should be coming down to normal. If those two markers go up, after 5 days, we start worrying about a patient going into liver failure. And if they are elevated beyond a certain level at the end of that first week, the risk of dying within the next 6 weeks is quite high. So we watch that closely. You heard reference to liver tests called AST and ALT, or the transaminases. Those always go up and come down, and they're not really a marker of function at all. It's just a sign that liver tissue has been damaged, and these enzymes are coming out of the cells. But it's the patient's mental status, that they don't become confused. It's that INR and the bilirubin that we follow afterwards that we watch come down to normal. And those are really the clinical and biochemical markers that we look at.
Terrific. And so a follow-up question that I think you've kind of touched on is, if liver markers increase but are still considered normal, is this cause for concern? So what you're saying is that the liver markers may increase, but it's as a result of some sort of trauma.
Right. As a result of the damage that we do in the operating room, they do go up, but we expect them within a week to come down. So once the patient is discharged from hospital, they usually have perfectly normal liver function. While that liver is regenerating, they have normal liver function.
And do you know if there's any correlation with or to fatty liver disease and metastasis? Are you familiar with that?
It's interesting because some of the patients I have operated on surprisingly have steatosis or fatty liver disease. And I was going to ask one of these guys if they've seen it in any of the drugs that they're using, because all these patients have been on long-acting octreotide. And I had one perfectly healthy guy, 50 years old, fit as a fiddle, had very bad macroscopic or macrosteatosis, fatty liver disease. He's not diabetic, he's not a big drinker, well, he's not a drinker at all, he's got carcinoid. So, I do not know, but I am seeing in this group of 10 patients, I've already seen 2 people with, substantial fat in their liver.
That you would not expect. Does anyone here, Dr. Rowland, Dr. Fisher, Dr. Kunz, does anyone want to weigh in on that?
Well, I guess I'll comment.
I think the mic will turn on now.
I guess I will
Magic.
comment. So that's a common scenario with colon cancer and removal of liver metastasis, because several of the drugs that we use can cause some subtle liver damage that you don't actually appreciate until you get in there and do the surgery. So we know, in working with our surgeons very closely, not to give too much of those particular drugs. And 1 or 2 of those drugs are starting to make some entrees into the neuroendocrine world. The drugs are oxaliplatin and irinotecan. But in general, I don't think octreotide causes steatohepatitis.
I agree.
Wonderful, thank you. Well, that is the end of our questions. Thank you so much to all of you for being here. We really appreciate it. To introduce our next speaker, I'd just like to tell you that he flew from Spain. to be here with us today Matthew Meyerson to describe his large-scale genome study of carcinoid. Thank you, Matthew.
Buenos dias. I came from Spain, but I am not Spanish and actually don't really speak Spanish. But I want to say it's, I feel like it's both really an honor and also in some ways a burden to be standing before you. And I think that's because it's an honor because the work that I'm going to be described is being supported by the Caring for Carcinoid Foundation, and it certainly is a kind of support that we greatly appreciate. And it's a burden in a way as well because, it's just so important that we can accomplish something that will be of value to all of you here. And as a cancer researcher, to be able, our ability to accomplish something of value is really indirect. That is to say, the physicians who treat carcinoid patients like Drs. Wolin and Zaruba and Drs. Fitzke and Botha really can make an impact that is direct and immediate and can really do something directly to benefit people with this disease. Whereas for those of us who are cancer researchers, we can achieve benefit only if we discover something that will be of value to those physicians who are treating the patients. And as we embark upon a project, we can never have any certainty that we will discover anything of value because that's, as people sometimes say, if you'll find it the first time, it would be called search rather than research. And so it's all that we can promise is that we will try to work with the greatest insight and that we will work as hard as possible in these goals. And then I just want to say the speaker at the beginning who read from her book was speaking about how to face, how one can respond in the face of great difficulty. And you were speaking about how some people in the face of personal difficulty, rather than responding by resentment, respond by giving love. And I think that I just want to say, my, special recognition to Nancy O'Hagan, who, by creating this foundation, to support, really all patients with carcinoid, has really taken, her own personal challenges and has met them by giving love to the whole community of patients. So with that being said, I'd like to say a little bit about the whole concept of going from genes to drugs. That is to say, by understanding the genes that cause cancer, we can hopefully find ways to develop new drugs that will treat cancer, and that this will apply in particular to carcinoid. And I'll be speaking today about, I spilled my coffee there. I'll be speaking today about finding the genes. And I just want to mention at the beginning, since I'm going to mention a couple drugs, not carcinoid treatments, but in general, Gleevec and Tarceva, that I get research support from their manufacturers, both Novartis and Genentech. And since I'll be speaking about EGFR mutations, that I'm an inventor on a patent for using this gene for cancer diagnosis. I don't think any of these affect in any way my opinions on these matters, but I just want to mention this. So I'm going to start by talking about cancer-causing genes and asking, why do we care what these genes are? And this is, first of all, because cancer is caused by changes in genes and in the genome. And I'll be talking more about that later. This can help us understand what causes cancer so that we can think in the right way about cancer. And this will affect our approaches not only to drug therapy, but also to prevention, to surgery, and even to nutritional approaches to cancer. And finally, and this is really the center of our goals, to be able to think about treating cancer by blocking the activity of cancer-causing genes. And this has worked with really quite dramatic examples for many diseases. One of the first major examples, the use of imatinib or Gleevec for the treatment of chronic myeloid leukemia with activation of a particular gene known as ABL. The use of trastuzumab or Herceptin for treatment of breast cancer with activation of, again, a different particular gene, ERBB2. And finally, the use of erlotinib or Tarceva and gefitinib or Iressa for treatment of lung cancer with activation of a third gene, EGFR. And on the next slide, I'm going to show an example of that last one and just speak a little bit more about the promise of gene-targeted therapy for cancer. So the need is that I think, as all of you well know, cancer overall kills over 500,000 Americans each year and millions of people worldwide. The old-fashioned or cytotoxic chemotherapy is often non-selective and highly toxic. The hope is that selective therapies against the altered cancer-causing genes can be highly effective and can exert fewer side effects. And one example is shown here in this CT section, transverse section of a CT from a patient with lung cancer. This is a patient of my colleague Bruce Johnson's at Dana-Farber, a leading thoracic oncologist who had an EGFR mutation in her cancer. And before treatment, you can see here, these are the lungs here, the air spaces show up as black, and here on the right side, because it's shown in the opposite orientation, you can see multiple nodules in the lung, which appear white in this image. After 2 months of treatment with Tarceva, these nodules have completely disappeared, and the patient was feeling much better. And there are many examples of patients with specific mutations who show these kinds of dramatic responses. They are not universal, and they are not always permanent. In fact, the majority of the patients who receive, for example, EGFR inhibitors do go on to relapse, but then there is the hope of developing second and third and fourth generation drugs against these same targets that may be effective for a much longer time. And so this is really the hope that motivates the type of work that we do and the intention of it. So I want to just talk a little bit about kind of what are the basic elements of cancer genetics. First of all, what is a gene? So genes are instructions to make proteins, and proteins are kind of like the factories of the cells. They perform the activities of cells, and billions, in fact, trillions of cells make up our body. Genes specifically are stretches of DNA, which is our genetic code, and I'm going to talk about more of that, and are used to make RNA and then protein. And the genes are the units of inheritance. And these genes are passed from parent to child and from cell to cell. So I just want to say right here, I know that several of you have given questions to Nancy that she's going to be asking at the end, but since I'm maybe presenting some concepts that are unfamiliar to you, please feel free to interrupt at any time when there are points that are not clear. Because if they're not clear to you, they'll probably not be clear to others. So, please interrupt me at any time with any questions. And if I don't see you, shout. So I've been speaking about genes and their role in cells. So every cell, I was going to talk first about DNA and the genome. So DNA is the genetic code, and it's made up of 4 letters, A, C, G, and T. And basically, it sounds like a pretty simple code, but there are just, the longer the stretches, the more combinations there are. And so, for example, for a stretch of 20 of these letters, there are basically a million different combinations. For 40 of them, there are a trillion different combinations. And so since our genome is made up of 6 billion of these letters, you can imagine that there's a vast number of possible combinations. So some of the DNA stretches code for proteins that I mentioned previously. Some code for chromosome structures, and I'll say some more about chromosomes in a second. And some DNA stretches control when or where proteins are made. That is to say, some cells have particular proteins, like blood cells make hemoglobin that carries oxygen. Other cells may have different types of protein, and these proteins are turned on and off at different times. And this is important for cancer because proteins may be turned on or off inappropriately. I'll talk more about that in a moment as well. Our genome, as I mentioned, in normal cells at least, is made up of 6 billion DNA letters, 3 billion that come from our mother, 3 billion that come from our father. So that's our genetic inheritance. And they're organized in 46 chromosomes, which are basically long strings of DNA pieces. And we believe that right now the number of genes encoded by our genome is around 20,000, although we don't actually really know this number accurately. We don't yet know all of the genes that are in the human genome. Even though we know all of the DNA, we don't know which part of them are functional units and make genes. And I'd been talking about cells, and I just want to talk about that because cancer is also a disease of cells. Cells are the unit of function in the body. They're highly specialized. So, for example, there are blood cells, muscle cells, brain cells. There are germ cells, which are egg and sperm. There are skin cells. Each different cell contains a complete genome, and there's 6 billion letters of DNA in each cell. And there are around 100 trillion cells in the human body. Most of these cells have exactly the same DNA. Our immune system changes. So in our immune system, to generate even more diversity, we get new DNA forms and parts of that can make antibodies. But cancer cells have genomes that typically change the most of all. And some cells can divide and make daughter cells in a highly controlled manner. Others can't divide anymore. They're called terminally differentiated, and they completely stop dividing. Examples of this are muscles and the brain. And cancer cells, I'll talk more about this, don't have the same controls on their division that others do. So this is a picture of cells here, and I talked about the DNA. That's stained green here, and the cell membrane is stained red, and then other functional parts of the cell, not involved in division necessarily, are in this black part. So how is a cancer cell different from normal cells? So partly cancer cells are like other cells. So they still have certain features, shapes, or proteins of related cells. So for example, a stomach cancer cell looks related to the stomach lining, and a carcinoid cell is still related to other neuroendocrine cells that secrete hormones. But cancer cells differ because they have different growth patterns. They divide when they shouldn't, and they grow in places where they shouldn't. So they've lost, if you will, a kind of social control of growth compared to a normal cell. The reason that cancer cells are different from normal cells is because their genome is different from normal cells. Almost all cells in our body have essentially the same DNA, with the exception in some small parts of the genome of the immune system cells. In contrast, the DNA of cancer cells is different from the normal cells in the same person. That's also called mutated. A mutation means a change in the DNA sequence or structure, and it implies a functional significance. And the genomes of cancer cells can change as the disease gets more severe or as patients' tumors become resistant to drugs. So cancer patients can be born with DNA sequence variations. These variations can affect the whole body. We call that technically the germline because it comes from germ cells such as egg or sperm. And these variations may be inherited from parents or may be new mutations in the patient. And these variations may increase the risk of cancer in a given individual. The major germline mutation that we know about for carcinoid syndrome is in a gene called MEN1 or multiple endocrine neoplasia type 1. There are probably others as well that we may not be aware of. In contrast, and I don't see that I have a slide on this, most of the changes in cancer are somatic. That is to say, they happen in the cancer cell and not in the normal cell. They're changes from the cancer cell from the rest of the body to the cancer cell. And my postdoctoral advisor, Bob Weinberg, talked about it. He wrote a book called One Renegade Cell, about how one cell develops mutations that really causes it to lose control. And that's why cancer, even though it's very common, if you think about it in people, that is to say, it's very common for people to get cancer. A high percentage of people in the course of their lifetime will get cancer. On the level of cells, it's very uncommon. Very few people get more than one new cancer. And since there are 100 trillion cells, for the cell level, the chance is about 1 in 100 trillion, which means we have enormous protections against cancer. But because we have so many cells and we're so complicated, those protections that we have against cancer get overcome in many people. So now I'm going to talk about the specific types of genomic changes that can cause cancer. So these are mutations. So I talked about the 4-letter genetic code, A, C, G, and T, and here's an example, and how these letters can code for proteins, and these 3 letters on the bottom represent the protein building blocks that are called amino acids. And so you can see, for example, here in this one, this represents one amino acid. You can have many different changes in this DNA code, GGT, that leads, for example, to AGT, and it gives a different amino acid as well. Another type of changes is you can get changes in the amount of a gene. We call them amplifications, which means they're amplified, you get more copies. Deletions, they're deleted, you get fewer copies. And here's an example of an amplification. You might go from 1 copy of this red gene to many copies. And this, what's shown here, is an image of a chromosome. You can get translocations, which basically means that 2 chromosomes break and they rejoin in a new place. And I said that part of the genome controls where and when genes and proteins are made. This can change, so this changes the specific function of the protein that's made, this type of mutation. If you get an amplification, you can often make more of a gene. A translocation can either change the function or make more of a gene. And finally, there are infections, and this is a cartoon of a virus throwing out new viruses. And an infection is also bringing in new genes into the body, and those new genes can change the way that cell growth is controlled. They basically change the action of the cellular genes and also can lead to cancer. Because the cancer genome is different from the normal genome, cancer cells have different requirements from normal cells for their survival. So in principle, we can find drugs that kill cancer cells but have much less effect on normal cells. And this is really the whole principle of cancer treatment. Because if you kill the cancer cells and you kill the rest of the cancer cells, if you kill all the rest of the cells, the normal cells in the body, that treatment's not going to work. So you have to have some selective advantage, specifically killing the cancer cells. And that's the same principle that we use to treat infectious diseases. We need to find ways that a bacteria or a virus has vulnerabilities that are different from our bodies. Similarly, we want to find what's different from the cancer cell from the rest of the body. And that's the goal of analysis of the genome. There are 2 kinds of cancer genes. One of them is called oncogenes. These genes promote cancer growth. They become, I made a mistake here on this slide. Oncogenes promote cancer growth, they promote cell growth in general, and they become hyperactive in cancer. And there are effective drugs that target oncogenes like imatinib. Tumor suppressor genes suppress cell growth, and this should say suppress cancer growth, not cancer drug. I'm sorry about that. They lose activity in cancer, and they're not yet any effective drugs for this class of genes. So my postdoctoral research advisor, Bob Weinberg, who wrote the book One Renegade Cell, used to make the analogy that oncogenes are like the accelerator of a car. And what happens in cancer is that they get stuck all the way down, pedal to the metal, making the cancer grow faster. And he said, in contrast, tumor suppressor genes are like the brakes of a car. And in cancer, the brakes are broken, and again, the cancer cells are growing out of control. And so here's a little bit of a cartoon to illustrate that. With a normal proto-oncogene, you have a little bit of pressure to make the cell grow, or in this case, the car driving forward. But with an activated oncogene, it's like you have a lot more force pushing the cell to grow forward. And in contrast, the normal tumor suppressor gene acts like a brake, and you can see it's good I didn't become a graphic artist, but the brake is shown here by this big rock. And in the cancer cell, the brake is broken, it's inactivated, and again, there's no barrier to the growth of the cancer cell. We don't yet know a lot about the carcinoid genome. Again, in the case especially of lung carcinoids, we do know one gene that is mutated. It's called multiple endocrine neoplasia type 1. It's associated with a familial syndrome. It's also mutated only in the tumors of some patients who don't have the familial syndrome, and that gene is in the class of a tumor suppressor gene. So now I'd like to talk about the Carcinoid Genome Project, work that we're beginning with the generous support of the Caring for Carcinoid Foundation. The goals of the Carcinoid Genome Project is to read the DNA sequence of 2,000 genes in 48 carcinoid tumors and in matched blood from the same patients. And our goal is therefore to evaluate the presence of cancer-specific mutations in this DNA, and that's why we're going to be comparing the tumor to the normal DNA from the same individuals. And then our goal is to perform experimental studies of these cancer-specific mutations to determine whether they are targets for drug therapy. So why would we want to do this Carcinoid Genome Project right now? It's because there's a technology revolution in genome analysis, because there are excellent sample banks in the carcinoid field that are supported in a significant part, again, by the Caring for Carcinoid Foundation, and because there's a great deal of hope for finding new drugs from possible discoveries, shown by drugs like erlotinib, for which I showed the results in lung cancer. So the technology revolution in genome analysis, especially since we're here in California, some of you may have heard of Moore's Law. Gordon Moore was the founder of Intel in Northern California, not far from Stanford University. And back in 1965, he said that integrated circuits get twice as powerful every 2 years. So what that means is that in 20 years, they get 1,000 times as powerful. And we've seen this has been true ever since 1965, and we've seen just the incredible improvements in computer and communication technologies that have affected all of our lives since that time. Well, genome analysis has really been leaving Moore's Law in the dust. It's been better than twofold improvement every year, and now it's actually closer to about tenfold improvement. There are technologies that are called next-generation sequencing technologies that allow us to read millions of DNA sequences at once. And just like electronics had a digital revolution, this is a digital rather than an analog approach to understanding the genome. That is to say, it's reading every individual sequence of every individual molecule at once, which we haven't been able to do before. And we're able to discover now all 4 of these categories of cancer genome alterations that I showed on that first cartoon: mutations, copy number alterations, translocations, and infections. And on the right-hand side is shown an example of one of these technologies that's been developed by a California company here in Southern California known as Illumina. And this is basically 3 serial blow-ups, and what you can see here is 4 different colors: blue, yellow, green, and red, representing the 4 different types of DNA letters, each of them read one at a time in all of these different spots. And then here you can see, there actually are millions and millions of these spots. And this is the actual size of one of these units. The penny is shown for scale. It's not yet the cost of sequencing a whole genome, but we're moving there pretty fast. And just to give you an example of that, the Human Genome Project, the first genome of one single individual, is actually a mix of people, was completed in 2001, and it cost hundreds of millions of dollars. We and others have recently completed the first complete sequences of genomes of cancers and the normal genomes from the same patients, and those have cost hundreds of thousands of dollars. So again, improvement more than 1,000-fold, and that improvement continues to be changing rapidly. So I think this is a great time to be initiating a project like this for carcinoid tumors. So second, carcinoid samples. So thanks to support from the Caring for Carcinoid Foundation and others, physicians and scientists around the world have been building collections of frozen carcinoid tumors, and we're developing an international network for the Carcinoid Genome Project, in which Drs. Matthew Kulke and Ramesh Shivdasani From my home institution, Dana-Farber Cancer Institute are participating. Drs. James Yao and Asif Rashid from MD Anderson Cancer Center. Dr. Sylvia Asa from the Princess Margaret Hospital in Toronto. So these are the initial members of the consortium, and we're certainly in discussions with others, and we'd like to bring as many physicians and scientists into this collaboration as possible. Finally, the hope for finding new drugs. First, our DNA sequencing efforts. At present, we're not yet planning to sequence the whole genome for cost reasons, but it's possible that that may change in the course of this project, depending on the rate of improvement in technology. So we're focusing on the genes that are known drug targets. Then we will, after we identify the mutated genes, we will test them in cell experiments to see whether they actually promote cancer. We'll also look for mutations that might predict response to known drugs that might immediately guide new clinical trials, even without the development of new drugs. And finally, we will make all of our data publicly available and freely available so that all physicians and scientists will have a chance to build on our results to make further discoveries. So those are our plans. We hope that we will be able to achieve something of value for carcinoid patients. And I want to express again, our special thanks to the Caring for Carcinoid Foundation and its many volunteers and donors who give us the opportunity to do this work and hopefully to achieve something worthwhile. Thank you.
Great. Thanks so much, Matthew. First question. In your genetic studies, have you found any carcinoid patients that have autoimmune illnesses, such as lupus?
So I think that's a great question. We have not, but I think that to really identify these patients and in general associations between carcinoid and other diseases, I think it's important to look at very large numbers of patients, and I know the BioConsortium supported by the Caring for Carcinoid Foundation is working towards this, and I'd like just to turn to my colleagues and ask if any of you have further comments on this.
That was a no. In your genetic studies, have you found any evidence of hereditary mutations giving rise to carcinoid and related neuroendocrine tumors? Many carcinoid patients seem to have a family member diagnosed with either carcinoid or FEO.
Okay, so in this regard, first of all, I mentioned the multiple endocrine neoplasia type 1 syndrome is one hereditary syndrome which is associated with an increased risk of carcinoid, and especially foregut or lung carcinoids. There's also an association between mutation, and patients with this syndrome can also get pheochromocytoma. Second, mutations in a gene called VHL, or von Hippel-Lindau, is associated with, to my knowledge, with carcinoid, to some degree, pheochromocytoma, and renal carcinoma. And again, I'll turn to my colleagues to correct me if I've misspoken about that. Okay, that is correct. But beyond that, there's generally an association between carcinoid tumors in one individual and the presence of carcinoids or other cancers in their families. And so where there's no association with either MEN1 or VHL. There are a couple other genes that are whose mutation is also rarely associated with carcinoid. But I think that further studies of these familial aggregations may potentially identify more germline genetic alterations, that is to say, more inherited alterations that would be associated with carcinoid. So I think this is a very important area for future research.
And what about the tests that can be done to identify these inherited diseases like M1, VHL, et cetera?
So basically, the testing for this would be DNA sequencing, and I think this is certainly worth. Personally, I think it would be very worthwhile for patients to pursue this. I don't think that there are yet systematically, nationwide, readily available for all patients, really good comprehensive mutation profiling tests partly because these have been very expensive to do in a broad scale. And I think that, again, the improvements in DNA sequencing technology are going to make the costs of such sequencing tests much more feasible and cost-effective. So we'll see vast improvements in the next couple of years. Again, I don't know, Dr. Fisher, if you want to comment further on this.
Yeah, thanks. I guess I would just want to add as another researcher that Matt's project, I think, is the most important thing going on in the country right now, Carcinoid. And all the guesses that Ed Wolin and I make at treatments are really kind of guesses, and they're largely empirical. Let's try this drug for the disease and see if it works. And we do make advances that way, there's no doubt, and some of those advances we are hopeful will have a meaningful impact on the disease. But this is the kind of science that can lead to major breakthroughs. And just something you touched on, Matt, about the family question is an excellent question. You should remember that the BRCA genes, the breast cancer genes that were identified, really was the result of this same effort at a huge cost on families with breast cancer, because then you enhance for the presence of the important gene. And so if there are families with carcinoid, that would be even more important to get those kinds of samples to Matt's lab or to other academic centers that will be participating with Matt's project. That will, I think, amplify the power of his ability to find the genes that are associated with carcinoid. And that's not been done for carcinoid.
That's a great point. Thanks, George. Yes, Dr. Wolin.
Just two things. One, I wanted to certainly second what Dr. Fisher has just said, that we're starting to approach an era of personalized medicine where people's treatments can be pinpointed by genetic analyses of tumors. We're not quite there for carcinoids yet, but hopefully this type of research will get us there sooner. The other thing is, in terms of genetic testing, the issue came up which family members should be tested. I think that the most important thing is that if families could be identified where there is a familial condition in a family, in other words, there are several individuals within a family that have a disease, those are the most important people to do genetic testing, and especially if there is a known gene mutation that can possibly explain it. Test the patient for sure, and then if the patient is positive, the other family members can be screened. For example, if someone has a thymic carcinoid, you can test for MEN1, which is an association, the multiple endocrine neoplasia type 1, or carcinoid of the lung in certain situations where it runs in the family, or other foregut carcinoids. Test that patient for MEN1. If that patient's positive, then you screen the family. There also are families that have an association of midgut carcinoids with non-polyposis colon cancer, or so-called Lynch syndrome. It's not a very common presentation in that syndrome, but it happens. And if there's a family that has some members with colon cancer, some members with carcinoid, by all means test the patient, and if that patient's positive, again, it could be a screen for other people. So I think that rather than just running to do genetic tests with the few genes that are available, use them when the likelihood of benefit is highest, since they are expensive tests, and the yield is very low if there's not a family history. And then the most important thing is trying to identify new genes and new targets, and that's what we're hearing about today.
Thank you, Dr. Wolin. Thanks for that insight. Dr. Meyerson, do you believe that race and or gender is implicated in carcinoid or other cancers?
Dr. James Yao, who's at MD Anderson Cancer Center and is one of the individuals supported by the Caring for Carcinoid Foundation, recently reported a large epidemiological study of carcinoid. And there were not significant variation inside the United States in kind of carcinoid frequencies by gender. There were significant variations by race in terms of particularly location of carcinoids, lung carcinoids being somewhat more common in Caucasians, carcinoids of the rectum being more common in African Americans and in Asians and Pacific Islanders. You know, what the reason for these variations are, and do these have to do with germline genetic differences? I don't think we know at this point, and but I think it's an interesting question. We certainly see in certain cancers, lung cancer, an area where we've worked a lot, there are very different patterns of mutations, for example, between East Asians and Caucasians. So I think it's possible as we go further into the genetics of carcinoid, even if the incidence rates are the same in different ethnic or racial populations, that we may see different causative mutations. Again, in lung cancer, there's a difference in rate of specific mutations between men and women in each of these populations. So I think it's possible in more detail, and we don't yet know the answer to that.
And just to highlight this article by James Yao, this came out in one of our e-updates that we highlighted. These e-updates come out for free monthly. If anyone missed that article by James Yao, which was an extensive overview of carcinoid cancers, please contact the foundation. We'll send that out to you right away. Matthew, this is, I think, a little bit of an overlap, but slightly different. What work is occurring to determine how genetics play a role in neuroendocrine tumors? And would the donation of blood from family members help provide evidence that there is a genetic link? If not, what tissues are necessary?
So I think that kind of in response, I think as Dr. Fisher and Dr. Wolin were speaking about genetic testing, and I do think that studies of blood from families with multiple individuals who've had carcinoid would be very valuable for mapping the actual genetic causes of the disease. For the second type, so again, the inherited or inheritable genetic causes. So there are these two types of genetics that I've mentioned, the germline genetics, which is inherited, or what you're born with, not necessarily inherited, and the somatic genetics, which is what happens in the carcinoid cells, but not the normal cells. For the carcinoid specific changes, it's important to have both the tumor tissue and the normal tissue. And so I actually recommend that, I actually think going forward, patients should think, if they have surgery, of making sure that their tumor is preserved and banked, and discussing this with your surgeons before the surgery, because I think this is going to become important for not only for discovery, but for diagnosis, not necessarily for today, but perhaps several years from now. And so I think just for patients to be thinking about this moving forward, I think is going to be very important. Not to have surgery specifically for the purpose of diagnosis, but if at this moment, if surgery is potentially curative or has benefit of treatment, to be making sure that your tissue is preserved as well.
What have you learned from other cancers that will help in evaluating the carcinoid genome?
So I think that studies of other cancers have identified a number of genes that we know to be mutated in cancers. So we've identified on the order of 100 to 200 oncogenes, and on the order of 50 to 100 tumor suppressor genes. And so each of those genes can be evaluated specifically in the setting of carcinoid. Some of those genes are associated with responses to specific drugs, and so it's particularly important to learn about these genes that are associated with responses to drugs. In the Carcinoid Genome Project, we'll be looking at all of the genes that are known to be either oncogenes or tumor suppressor genes in other cancers in the setting of carcinoid tumors.
How can neuroendocrine tumor patients benefit from the Human Genome Project and Tumor Sequencing Project?
So here, I think first the Human Genome Project has really defined the structure of the human genome, and the Tumor Sequencing Project and the project that the National Institutes of Health is running right now is called the Cancer Genome Atlas. It's the biggest, it's a big study of these types of genome alterations that I described in many, many cancers. The goal is actually, the project has just been extended, the goal is to sequence about 10,000 cancers over the next 5 years. And so again, I think this should be, however, unfortunately, even looking at 10,000 cancers does not cover all cancer types, and many of the more rare cancer types, such as carcinoid, are not likely to be covered in this project. But I think that the genes identified by projects like the Cancer Genome Atlas, again, will be very valuable for further study in carcinoid as we expand carcinoid genome efforts.
How do researchers share genomic results to find druggable targets and advance future research?
So the way, I guess we share the results by two different ways. First of all, we make all of the data from these projects available directly to the scientific community on the internet through kind of web servers, And I think this gives everybody an access to look at the primary data, which without, any influence by our interpretations, and to use the data, whether in conjunction with data that they have, or together with data on other tumor types, and try to make conclusions. The second thing that we do is we analyze the data and make our conclusions, and we publish these results in scientific journals. And these published studies, before they get published, are evaluated by other scientists who try to judge, what's the value of them, and then give us further suggestions to try to interpret them before we publish them formally.
And I'd just like to elaborate on that. There are a few things that the Caring for Carcinoid Foundation requires when funding scientists. One is 0% overhead. Another is a requirement that each of our scientists share their results in a collaborative manner with every other scientist in the field, because we are struggling to move forward at a very rapid pace, and it's important to have collaboration. Matthew, will your study help develop biomarkers for carcinoid patients?
I think if we identify carcinoid causing mutations, these mutations will be valuable biomarkers for studying carcinoid, and may be used for, these, and they may be biomarkers of different sorts. For example, in some cases, particular mutations will predict what a patient's prognosis may be. In other cases, they may predict whether patients are likely to benefit from a particular drug. And in other cases, as I say, they may guide future clinical trials. So there are a number of different ways in which these findings could lead to the development of biomarkers.
Wonderful. Thank you very much, Matthew.